Our next talk will start like maybe she is crazy. Just relax. She is just in need of carbs. So our next speaker, Dr. Sagar Barasara, is going to deliver talk on the evaluation of hypoglycemia in non-diabetic patients.
Good morning to all the seniors and dear colleagues, APR, ESR, and all of for being present over here. It is said that diabetes is a bread and butter of our practice as a physician. So I can say the hypoglycemia can be considered as either pickle or masala chai with this bread and butter. So today's my presentation will be hypoglycemia, physiology, causes, but my focus will be on the critical sample. What is critical sample? How to find the culprit, and few cases which we can usually find in our clinical practice. So begin with the presentation. So there is one OPD scenario like 42-year-old female, apparently well, 65 kg, 5 feet, BMI around 32, and she is complaining like weakness, headache, both થાક લાગે છે, and all of a sudden enthusiastic our assistant do the HGT with glucometer and it is 71. So should we consider this as hypoglycemia and we should start immediately treatment, or we should evaluate, or something else we should be done? So how many want to consider it as hypoglycemia from the audience? No. So all of you are correct. So there is considered as a Whipple's triad. Okay, there should be classical symptoms of hypoglycemia, which we will discuss in the next slide. Okay, autonomic symptoms and neuroglycopenic symptoms should be there. Sugar level below 55, below 3 millimole per liter. Some say 54, some say 55 because of this multiplication factor. It should be below 55. It should be done from the lab and must be from hexokinase method, not GOD-POD is also okay, but gold standard is hexokinase method. There are some semi-autonomous machines which are done by the routine enzymatic method, and it is not that much reliable. It should be done from the good reliable lab. Once we treat the symptoms with the either glucose or food or any other way, the symptoms must be resolved. This is the beginning of the evaluation of hypoglycemia symptoms. So this is a Whipple's triad should be fulfilled to consider to label as a hypoglycemia. So what are the symptoms of hypoglycemia? When there is hypoglycemia, there are two, brain is deprived of the glucose, and there is a neuroglycopenic symptoms like irritability, confusion, seizure, transient neurological deficit, loss of consciousness and visual disturbance, and the sympathetic system activates by the hypoglycemia. This results in the sweating, weakness, tachycardia, palpitation, tremor, nervousness, hunger and paresthesia. So what is the physiological, I want to ask, what is the first physiological defense to the hypoglycemia? Like insulin, glucagon, growth hormone, cortisol, symptoms. So what is the first defense of the hypoglycemia? So hunger may be correct, but before hunger, the insulin reduces in the body. So when there is a hypoglycemia, the pancreas and brains becomes activated. The first defense is to reduce the insulin level. When our glucose level is in the range of 80 to 85, the body decreases the insulin production and it start increasing the glucagon production. So first defense is like insulin, decrease in the insulin level. So first defense to hypoglycemia is decreasing the insulin production. When further sugar drops around 65 to 70, the glucagon production start increasing. After that, the autonomic response is generated. It increases the epinephrine level. And if hypoglycemia is prolonged for very prolonged duration, like 30 minutes, 40 minutes or 60 minutes, it start producing the cortisol, increasing the growth hormone and cortisol hormone. After that, the symptoms appears around 50 to 55 level. And if glucose level goes below 50, then the unconsciousness and neuroglycopenic symptoms, severe neuroglycopenic symptoms appears. So what are the causes of hypoglycemia? So basically we classify like critically ill patient, those are indoor ICU settings, severe and terminal malignancy, that are the critically ill person. That will not be a focus of our discussion today's topic, but we will discuss the apparently healthy person, walking, talking person having a repeated episodes of hypoglycemia. We will focus on this topic. So this can be classified as a insulin dependent and insulin independent. So medically, in seemingly well individuals, endogenous hyperinsulinism and external insulin use or tablet use. So in endogenous hyperinsulinism, the causes are insulinoma, functional beta cells disorder, autoimmune hypoglycemia, insulin secretagogue, and and in accidental, surreptitious, and malicious use of medicine or insulin in the cause of hypoglycemia. So when we are discussing any topic, the history is the most important. So we need to discuss the duration of symptoms, episodes of hypoglycemia, duration of symptoms, total duration of illness, relation to food, whether it is appearing before the food, after food, how many hours after the food, in the daytime, nighttime, particularly fixed time, because the particular, like someone has accidentally used the mixtard, then the symptoms of the hypoglycemia must be in the midnight or in the early morning. Those having a insulinoma, having symptoms all around the day, but mostly in the fasting hours. Those having autoimmune hypoglycemia, the symptoms of hypoglycemia must be around postprandial phase, like 4 to 6 hour postprandial phase. We need to discuss the relieving factor of these symptoms, like food intake or something else. We need to discuss the history of past illness, medicine, and we also need to discuss the profession of the person who is presenting with the hypoglycemia, and also the family history of diabetes and their treatment protocols. So what is the, when patient present in our OPD or in our emergency, we decide this is when we check the sugar with glucometer, and if it is very low, then we should not rush to treat this patient. Anyway, patient is unconscious, we are going to apply a IV cath. So we must collect a sample at that time before giving a treatment. This is the most important thing. This is the takeaway message from my PPT. Don't treat the patient first, take the sample first. And this is the critical sample. We need to collect one sample for plasma glucose, one sample for insulin C-peptide, acetone bicarbonate, or sometimes cortisol or other hormones. So we need to collect all three vials, one fluoride, one EDTA, and one plain. Plain must be around 4 to 5 ml, because we can do the repeat investigation from this sample. This is the most important thing when we are evaluating seemingly well patient for hypoglycemia. So how to interpret this critical sample? So in normal condition, like today I develop hypoglycemia, if I am all right, so my insulin should be very low. Insulin and C-peptide are produced in equimolar. If 1 mole of insulin is produced, then 1 mole of C-peptide is there. So C-peptide should be also low. Insulin generally suppress the ketone generation. If my insulin is very low, then my ketones body should be very high due to the counter-regulatory hormones of glucagon and growth hormone and cortisol. So ketones should be high. Bicarbonate should be normal, because there is no any error of metabolism in my body. Cortisol should be around very high if hypoglycemia is severe and very prolonged duration. And if you give me the glucagon, there should be no further increase in the glucose, because already my glucagon and counter-regulatory hormones are very high. So as a normal subject, this is the normal phenomenon, normal response in a normal person. So now we will discuss 4 to 5 situations. I will give you a clue, and you just tell me what should be the insulin, C-peptide, acetone, and response to glucagon is. If I have taken insulin as a malicious purpose, today I don't want to go for work, and I have taken insulin. So what would be my insulin level, C-peptide level? So insulin is high. Insulin is given from exogenous so C-peptide will be very low. And my acetone will be normal, because exogenous insulin is given, so ketogenesis will be suppressed. And response to glucagon will be there, because insulin overaction is there. So once we give the glucagon, it will increase the sugar level. So this is the exogenous insulin level. Like I have taken the glibenclamide. So what will be my insulin level? It will be high. glibenclamide acts on beta cell. So my C-peptide level will be very high. And there will won't be any acetone will be low, response to glucagon will be present, but sulfonylurea screen will be positive. Right now I am taking a methyl alpha methyl. I am energy enthusiastic. I want a multivitamin. And I have taken alpha methyl lipoic acid. And I develop an autoimmune hypoglycemia. In autoimmune hypoglycemia, the antibody will be there. IgG type, it will binds with the insulin and in the postprandial phase. But this antibody will be slowly released after, it's a time or, so this antibody will be slowly released after few hours. So there will be delayed hypoglycemia. So it is called a autoimmune hypoglycemia, but there is some particular characteristic feature. In such case, insulin level will be very, very high, like 100 or something like that. But in C-peptide will be high, but it will be like borderline high, from range from 0.6 to something 2 or 3, around 3. Ketones will be low, response to glucagon will be present, and if we screen for an anti-insulin antibody, it will be present there. So another situation, if there is an insulinoma. So insulinoma will act like endogenous hyperinsulinism. So in insulinoma, the insulin will be very high, C-peptide will be high, and acetone will be low, and response to glucagon will be present. There is, if IGF-1 is produced from the tumor, like paraneoplastic syndrome, then there will be low insulin, low C-peptide, acetone will be low in such situation. And low insulin, non-insulin, non-IGF factor, like someone having a hormone deficiency or Sian syndrome, then there will be a low insulin, low C-peptide, high acetone, and response to glucagon will be absent. So this is the most important, most critical, most factor to evaluate the hypoglycemia cases. So if you want to find the culprit, once we have confirmed the hypoglycemia, then the next step is to confirm the etiological factor. So once the endogenous hyperinsulinism is confirmed, next step, the first line investigation is to, first time investigation is to do the CT abdomen. It should be triple phase. We can ask our friend to do a early arterial phase to better yield of this lesion from the pancreas. Next step of investigation, we should ask for our gastroenterologist friend to do a endoscopic ultrasound, because pancreas is a retroperitoneal organ, and it will very close proximity to the duodenum. We can analyze the lesion. Next step is do the functional scan. There are 3 types of functional scan available in Gujarat. We can do it from Rajkot or in Ahmedabad also. Gallium DOTA-NOC and DOTA-TET scan. It identifies the SSTR2 and 5 receptor, mostly used for the insulinoma as a first line investigation. Extending DOTA-PET CT, that also identify the GLP-1 receptor. It is the next line of investigation, or may consider in options to GLP-1 or gallium DOTA-NOC scan. And F-DOPA-PET CT, mostly used in congenital hyperinsulinism cases in children. So this is after the, and few times we can use a sulfonylurea screening. This is not available in commercially, but in few toxicologist lab and few institute in India, we can do this screening and anti-insulin antibody to rule out the autoimmune hypoglycemia, or else we can say the Hirata syndrome. So now begin with the case capsule, 7 to 8 cases. I want all of you to get involved in these cases. So first case is 32-year-old male from Doraji. He is a medical store pharmacist, brought to emergency in Doshi Hospital. He had a history of repeated episode of hypoglycemia, only in the midnight or early morning, not any other time. And he was treated for repeatedly for these symptoms, few times having a GTCS, and local treatment was given. This time the severe episode, he was admitted to the ICU. So next step is to do critical sample analysis. So this is the critical sample. Glucose is 38, insulin in such a low sugar level, insulin should be very low, below 3. But here it is a 34, is very high. C-peptide is less than 0.1, so it should be considered as a low. It should be below 0.6, it is a very low. acetone is absent, bicarbonate is normal. So high insulin, low C-peptide. What should be our diagnosis here? Exogenous insulin, perfectly. So what insulin he might have taken? Must be mixed-start, because in periphery the use of mixed-start is very high. So particularly the midnight and early morning hypoglycemia signifies the long-acting insulin use. So next question is similar case. He was preparing for a UPSC and he failed. He was a CDH already in government institute. He has a contact with multiple pediatricians. And he also admitted to the corporate hospital with unconsciousness. Similar profile, high insulin, low C-peptide level. He had taken the also mixed start, and this is the case of exogenous insulin use. So there is a one quite interesting analysis. The day by day we are using the insulin analog. We have modified the original human insulin. But these insulins are not identified by the recent CLIA methods, which we are using, which we are ordering in our practice. So the old previous insulin, human ectrapid, insulin, big start, NPH, this can be detected by the lab assay. But these newer insulins cannot be detected by these current assays. So for these cases, we need to do the LCMS. So when we have a strong suspicious for such cases, mostly it is a clinical analysis. This patient doesn't come for a follow-up usually. Once we identify, once we confront them, mostly they will not come back to us for next episode. But this is sometimes if we found very low insulin level, but very strong suspicious, then this should be considered they might have used a newer analog. So coming to second case, 56-year-old male, father of a nurse. She was, after a CABG, she was prescribed multivitamin tablets, and after 1 month, he suddenly started developing sudden onset of severe classical hypoglycemia symptoms, mostly after 4 to 5 hours after the meal. And we evaluated their medicine. It was alpha lipoic acid, multivitamin, clopidogrel, and anti-ISD treatment. So he come to in very stable condition. There was no critical sample available with us. So we did a mixed meal test. It contains an equal amount of protein, carbs, around 300 calorie meal, and we stimulated the insulin release. And after that, there was a hypoglycemia around 5 to 6 hours after this mixed meal test, and this was his critical sample analysis. Sugar was 51, insulin was very, very high, like 100.5. C-peptide also high, but not that much in equimolar concentration of insulin. Acetone was normal, bicarbonate normal. So what would be our conclusion from this case? What is the etiology? Yes, so this is a autoimmune hypoglycemia. Very, very high insulin compared to C-peptide, IgG type, dissociated very slowly. So most of these cases develop hypoglycemia in postprandial phase, and few times they develop hypoglycemia in early morning or fasting states also. So this is a immune-mediated hypoglycemia. The culprit is here alpha lipoic acid or maybe clopidogrel. So these are the medicines involved with the autoimmune hypoglycemia. Most of the cases we find with the antithyroid drug, alpha lipoic acid, clopidogrel, these are the culprit drug which are involved in the autoimmune hypoglycemia. So next case, 54-year-old male from Rajkot having a recurrent episodes of hypoglycemia, weight gain of 8 kg in 1 year. This time he presented with the GTCS, first episode, admitted and diagnosed to have hypoglycemia. This is the critical sample. Low sugar, high insulin, high C-peptide, acetone absent, bicarbonate normal. So this is a case of probably endogenous hyperinsulinism. So correctly, you all have identified this is a case of insulinoma. We straightforward ordered the CT scan. This revealed the around 1.5 centimeter of pancreatic lesion, insulinoma. He is subjected to surgery and he is fine right now. This is the case from periphery. See how neglected this patient was. She had a recurrent episode of hypoglycemia for last 3 years, and she was prescribed steroid for these symptoms. She had become cussingoid, and after that she was referred for evaluation of hypoglycemia. Initially, if we have stopped the steroid, her symptoms had worsened because cortisol deficiency will be there. It will aggravate the hypoglycemia symptoms. So we tapered her glucocorticoid in next 3 to 6 months. After that, when she developed the symptoms in UNA, we coordinated with our physician colleague and we did the investigation. This was the critical sample. Sugar was 24, C-peptide was 11.4. Sorry, this is mistake, but this is the insulin was 7.67 and C-peptide was 0.74. Both are high for that insulin level. And we did the CT scan in the periphery. They have identified the pancreatic lesion. This is the insulinoma. So when the patient is in periphery, we can coordinate with our physician colleague and we can investigate them. The most important thing is to not to treat the hypoglycemia, but to take the critical sample and to analyze this critical sample. So after that, he was subjected to US and it confirmed biopsy was taken from this lesion and she is subjected to surgery. This is the most interesting case. This is the first insulinoma case as a trainee I have evaluated. Patient was having a violent behavior episodes early morning in the ekdam gada gadi kari muke and he was healthy like 70-80 kg. 5 jana pakde to માંડ ઊભું રહે એ રીતના એપિસોડ frequently આવતા હતા. And he was treated in psychiatry department. And he had one episode of seizure, so he was referred to neurology department. They have started the anti-epileptic drug. And then he was referred to evaluate for weight gain and acanthosis to us. We did the fasting sugar as a routine workup and we found a sugar of 66 and from there suspicious was arise. And we did the 72-hour fast. He was hypoglycemic after fasting of only 8 hours. The critical sample is like insulin is very high, C-peptide is high and he was an endogenous hyperinsulinism. But here when we did the triple phase CT, it was normal. So next step ideally should to go to the endoscopic ultrasound. But unfortunately at that time the US is not working in our Nair hospital. So we subjected to DOTA scan. But unfortunately DOTA scan was also normal. So we did the GLP-1 extending scan. It revealed it highlights the lesion. There was an insulinoma in the head of the pancreas. And after that when US was started working, we confirmed it with the US. We subjected to FNSC. And then we put the patient for the surgery treatment. It was a 1.7 by 1.3 centimeter lesion. This is the most difficult case which I have treated of insulinoma. He was diagnosed having a neuroendocrine tumor already, having a liver mets, inoperable, stage 4 lesion. But he was advised few treatment but delayed by always stage 4 cancer, neglected by the relative. And suddenly she started developing 30 to 40 episodes of hypoglycemia in a day. She was mostly bedbound and one day she presented to in my OPD. In endocrine OPD you can't find any emergency medicine, but fortunately we were able to do the critical sample analysis. When I do the HGT, it was just 29. And I was also shocked at 29 glucometer ma avi shake em. Then I checked the net, it was a Freestyle Libre 2 glucometer. Up to 20, it can analyze. Below 20, it reveals the low sugar level. So it was actually low sugar. It was below 40 from the lab analysis. Insulin was 108, C-peptide was 7.64. This is the endogenous hyperinsulinism. This is her US picture. And this is FNSE from the same lesion. It revealed the metastatic neuroendocrine tumor. It is a low, well-differentiated Ki index of more than 51. So she was started on small frequent meal, complex carbohydrate diet. She was given a octride injection, 30 mg depot every month. So this time we repeated first 2 injections in the gap of 15 days. It cost around 22,000. Then she was given a lutetium DOTA therapy. It is a peptide receptor therapy like આપણે જે iodine treatment આપતા હોય, radioactive iodine ablation, like lutetium DOTA therapy, 1 cycle is given. Chemotherapy, capecitabine and temozolomide was also given. And she still having a hypoglycemia. We have given a Balila diazoxide, 50 mg 3 times a day. It is a potassium channel opener and reduces the insulin secretion. And after all this treatment, She is now right now off there is no hypoglycemia episode after this treatment, and she is planned for a next PRRT therapy. So this is the post PRRT scan, having a huge uptake in the liver as there is a mets in the liver, and we have reached over here the second capacitor band cycle is going on, and the PRRT is planned after the 1 month. So this is the complicated case, and this is the most neglected. I want to drain attention of the when we are evaluating the hypoglycemia. This patient presented to Surendranagar Medical College. She is having a GTCS and left hemiparesis. She is given all the treatment of GTCS and hemiparesis, but sugar was not evaluated. When there was no improvement after 2 days, she was referred to Rajkot. Here she was evaluated in private hospital, and she is diagnosed to have a suddenly hypoglycemia. Critical sample analysis revealed the endogenous hyperglycemia, hyperinsulinism. When we evaluate the CT scan, there was a hypoglycemia. This MRI brain was done initially. It was hypoglycemic encephalopathy. Critical sample, there was endogenous hyperinsulinism. And when we did the CT abdomen, it was a case of insulinoma. So patient was bed bound if we delayed the diagnosis. But fortunately, after treatment and physiotherapy and strict timely intervention, she is now walking with support. So if we delay the diagnosis, if we miss the critical sample, it will be very, very detrimental for the patient in few cases. So always do the critical sample analysis. Case number 4, 68-year female from Rajkot, healthy, no significant past history, had a lunch and found unconscious GTCS in the evening. મતલબ કે પેશન્ટ છે, બપોરે જમ્યું છે, સૂતું છે, ત્યાં સુધી કાંઈ જ સિમ્ટમ્સ નથી. ઇવનિંગમાં પેશન્ટ ઉઠતું જ નથી. સડનલી એને હોસ્પિટલે લઈ જાય છે. ઇટ વોઝ અ હાઇપોગ્લાઇસેમિયા ઓફ 31. Insulin, C-peptide suggests the endogenous hyperinsulinism. We did the CT scan. It was normal. There is no clue. But when we check the history of her husband, he is diabetic, he is taking glibenclamide, and she might have mistakenly taken the sulfonylurea. So this is an endogenous hyperinsulinism. Very difficult to diagnose, but likely diagnosis is that. And last case, middle-aged or late elderly female having a recurrent episode of hypoglycemia, history of secondary amenorrhea, no menses after second delivery, history of postpartum hemorrhage. Sugar is 46, insulin is very low, C-peptide is very low. So we ordered the hormonal workup. It is a central hypogonadism, central hypothyroidism, and central hypocortisolism. This is the case of Sheehan syndrome, pan-hypopituitarism. So I would like to end over here with the take-home message. Always confirm the Whipple triad. After confirming the Whipple triad, we need to do the critical sample analysis. Approach with the logic. Each hypoglycemia is not, we should not treat the glucose value. It is an opportunity to diagnose the situation. And stay curious, stay systemic, identify the uncommon thing among the most common presentation hypoglycemia. Thank you for the attendance. Thank you so much.